Our next speaker is Dr. Lisa Sammaritano. She's Associate Attending Physician, HSS, and she's Associate Professor at Weill Cornell Medical College. She received her medical degree at Cornell and was a intern and resident at New York Hospital, and then a fellow at HSS. And she gave this talk at ACR, and people were coming out raving, and they said, you got to get her for CCR. So she's going to give us a talk on lupus pregnancy, management, and outcome.
Thank you so much. It's such a pleasure. Thank you for the invitation. The talks have just been outstanding, and I hope I can meet those same high standards. So I am going to talk about lupus pregnancy and management, and this is a little bit expanded actually from the talk at the ACR because I have a little bit more time. So I will cover a couple of other issues that I think are especially important to the whole question of pregnancy in our lupus patients. I do not have any disclosures, although most of the medications that I will mention are not approved for use in pregnancy. So, please be aware of that. So these are some evidence-based references. We actually published a textbook on contraception and pregnancy in rheumatic disease patients last year with Bonnie Burmis from the Brigham, and it covers this topic and many more if you're interested. So what I'd like to do in this talk is sort of cover things in three parts. First, I just want to go over a little bit of the important things about this stage of a woman's life called pregnancy and why it's particularly important for our patients with lupus. And then what I will do is just talk a little bit about risk factors and go through specific patient scenarios to try and gain an understanding of how we handle each of these problems. And I should say, you'll notice that each of the patient scenarios is really sort of a pure issue. In reality, obviously, we have patients with one, two, or all of them, but I thought it would make it easier for the purposes of our discussion. So, pregnancy affects the maternal immune system as well as multiple other systems, but affects the immune system in a number of ways, and it has to do that, right, in order to ensure fetal survival. And I'm sure you're familiar with these. Oops, that's not what I wanted to do. Okay, so cell-mediated immunity is depressed. That's why pregnant women are more susceptible to certain infections, such as listeria. Immunoglobulin secreting cells increase. There are pregnancy-specific proteins that also suppress lymphocyte function. And then a Th2 cytokine profile is dominant and may be important in sustaining a healthy pregnancy. So why is this important for our patients with lupus? Well, obviously, lupus is an autoimmune disease with changes in the immune system. And so these pregnancy-induced changes in immune function or in other systems may affect manifestations of lupus. For example, lupus flare, which we do think is probably at least slightly increased in terms of risk during pregnancy. The autoimmune dysfunction of the lupus itself can certainly affect maternal and or fetal outcome. For example, antiphospholipid antibodies present in a third of lupus patients and a very important risk factor in terms of outcome for lupus pregnancy. Transplacental autoantibodies may directly affect the fetus. Obviously, we heard about Sjogren's syndrome, but this is another important manifestation, if you will, of both Sjogren's and lupus. It's the antibodies themselves that convey the risk, regardless of the underlying diagnosis. And then finally, severe maternal illness or damage can affect both maternal and fetal outcome, so significant renal insufficiency or severe disease activity. Normal pregnancy changes, separate from the immune system, can worsen connective tissue disease manifestations. And so, although this is by no means an exhaustive study of physiologic changes in pregnancy, it's just a few slides to make the point that you need to think about certain of these organ systems in your patient with lupus. So intravascular volume goes up, it has to, right, to perfuse the placenta, and that can stress patients with renal or cardiac compromise. Similarly, GFR has to go up, can increase pre-existing proteinuria and put additional stress on the kidney.